Welcome to our podcast, Oncology Morning Commute, Managing Therapies for the Non-Small Cell Lung Cancer Patient. Morning Commute is developed in collaboration with At Point of Care and Projects and Knowledge and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Merck. In this podcast, Beth Sandy and Marianne Davies continue their discussion on non-small cell lung cancer and immunotherapies. How do you choose and schedule the best treatment for each patient, and how should toxicities be managed? Information about the faculty and disclosures can be found by visiting morningcommutepodcast.com/NSCLC6. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Beth Sandy is a nurse practitioner with the Abramson Cancer Center at the University of Pennsylvania, Philadelphia. Marianne Davies is an associate professor of medicine and a nurse practitioner at Smilow Cancer Hospital in the Yale Comprehensive Cancer Center in New Haven, Connecticut. I am Candace Hoffman, managing editor of Morning Commute. Beth Sandy will begin our discussion.
Okay, welcome back, Marianne. We covered a lot of ground in our last two podcasts, talking about first molecular profiling and then how we use immunotherapy, whether single agent or combination. Let's talk a little bit about patient management and the treatment responses and side effects, especially the toxicities to watch out for. I think to start, we'll just talk about everything we're trying to do is fostering, shared decision-making and the patients being involved in that. I think there's a couple things on prepping the patient about, when they're likely to see a response and how often they have to come in. During COVID, some of these immunotherapy drugs have come out with new dosing schedules. Now switching from every 3 weeks to every 6 weeks is a possibility, or every 3 weeks to every 4 weeks, every 2 weeks to every 4 weeks, broadening that interval between the time we bring them in. Just take pembrolizumab, for example. We can give it every 3 weeks, or we can double the dose and give it every 6 weeks. Have you done that? And what has been your experience with that? Do patients like it?
So that's a great question, Beth. And yes, we have had the opportunity to make that treatment decision. Part of that is going to be based on the patient and their how stable they are. And so if I have a patient who's very medically stable, and they don't want to come into the clinic quite as often. And also if they're very reliable in terms of reporting any potential side effects, we may consider increasing the interval in terms of the dosing. However, if a patient has underlying comorbid medical conditions, if they're experiencing any kind of toxicities, even if they're subtle, then I'm less inclined to increase the interval for them coming in, because it's incredibly important that we monitor patients closely on the immune checkpoint therapy. While typically very well tolerated, the toxicities can become more serious or even life-threatening if they're not acted upon and managed in a very swift fashion. So again, if a patient has a good support system, if they're reliable in terms of their ability to report the onset of any symptoms, then I might offer them an increased interval of the schedule. Or if they live, let's say, far away. And the other part that's, if they live further away, collaborating with their primary care providers in their areas to assist with monitoring of toxicities can be very, very valuable.
Yeah. Right now, oddly, that he is having a little bit of trouble swallowing. He's just not really sure why. He said he feels like food gets caught in his throat. Now, he's only every 6 week dosing of pembrolizumab, and I don't want to wait 6 weeks to see him. I'm hoping it's not a rare myasthenia gravis, but it could be. So now we're in the process of working that up. But that's not someone I'm going to say, yeah, I'll see you in 6 weeks. I'm sure it's fine. So yeah, I would agree with you. It's, you have to take really each patient individually before we decide to do that. And then Marianne, you had alluded to prepping the patient about a treatment response. Can you briefly touch on that?
So certainly, many of our patients, if they, we've had all of these new novel therapies that have come to market in the past several years. So not every patient has prior experience with cytotoxic therapies, but some may have, have heard from other, family members or friends or whatnot. Oftentimes patients come in and they get their treatment, and the first thing they ask is, when am I going to know if this is working? How often do we do scans so that I understand if I have a response? Cytotoxic therapies in general, we might see a response within even 6 weeks of therapy. However, in general, the responses to treatment from immune checkpoint inhibition tend to take longer because it's that activation, the underlying mechanism of action of activating the body's immune system to go out and lead to tumor death can take much longer. And so sometimes it can even take 12 weeks and even 16 weeks in some cases to actually see a response. So setting that expectation for patients is of critical importance so that they're not disappointed on that first, depending on when the first set of scans are going to be scheduled.
That's a great point. So let's move right into toxicities. I think the one I really want to start with is pneumonitis. These are the immune-mediated adverse events. So I'm not talking about fatigue, nausea. Those are some of the common side effects that we see with all cancer agents, but the specific ones that are related to the immunotherapy causing inflammation within an organ system. So pneumonitis is one that we see more commonly in our patients with lung cancer than they do perhaps with melanoma or breast cancer or GU cancers, where we also use immunotherapy, but they're seeing lower rates. I think it's likely because the organ that we're treating, the lungs, a lot of these patients have had radiation to their lungs before. My patients will often present with a pretty quick onset of dry cough or shortness of breath. It's something, and they're often hypoxic. So knowing what their baseline pulse ox is before they develop this, and you can see it very easily on a CAT scan. I mean, when you get that CAT scan, this is a pretty obvious drug toxicity or organizing pneumonia, which is an inflammation within the lungs, our radiologists often call it. Miriam, what has been your experience with patients developing pneumonitis, how you're treating it?
So that's a great question, and particularly challenging in this time of COVID because the diagnostic imaging can mimic other inflammatory processes in the lung. Many of our patients do start out with interstitial lung disease, and so their CT scans are not clear to begin with. But typically, more of the classic patterns on CT scan for patients are going to be kind of patchy areas of what we call ground glass opacity, so kind of mimicking that organizing pneumonia. And so it's important when we're ordering our scans that we let the radiologist know exactly what we're looking for, what our differential diagnosis is, so that they can speak to those specific findings on the CT scan. We work very closely with our pulmonologist in helping to manage this specific toxicity. As with any immune-related adverse event, what we want to do is rule out other causes first. So immune-mediated or immune-related adverse events are really a diagnosis of exclusion. So it's an inflammation of any organ system, as you mentioned. So you rule out any infectious causes or any other kind of insults that could have happened that have led to this. And once in your differential, you've diagnosed this as an immune-related adverse event, we hold immune therapy. That's the first step. And then specifically if it's grade 2 or higher, meaning it more significant or symptomatic. And then typically we initiate corticosteroid therapy. That is really the mainstay of how we manage these toxicities, because what we're trying to do is suppress the immune response and suppress that autoimmune attack on normal healthy tissue. And so, again, steroids are going to be our mainstay. We monitor the patients very, very closely.
Can you be more specific? What steroid do you normally use?
So methylprednisolone and typical or prednisone equivalent, and it's typically 1 milligram per kilogram per day. And patients stay on that. If they're more symptomatic or hemodynamically unstable, they might get admitted to the hospital for IV steroids. But if they're stable, we can treat them as an outpatient. And again, this is something that they stay on that dose until the toxicity is reduced to a grade 1 or less or recovered. This is not a Medrol dose pack, and that's what's really, really important for those in the community. Patients have to be on this, and oftentimes they may be on that dosing for at least 2 weeks before they have recovery or improvement. And then it's a very slow taper over 4 to 6 weeks. Sometimes it takes even longer to taper it down very slowly to assure that there's not a flare of the response. So whether it's pneumonitis or any other organ inflammation, the corticosteroids are the treatment of choice. And once they're tapered off, you can make a decision as to whether or not we re-challenge with immune checkpoint therapy, or if we need to make it permanently discontinue. And if patients don't respond within the first few days, then additional immunosuppressant agents may be used to help suppress that. One of the things I just want to, we educate our patients, and they're nervous about reporting symptoms, but it's really critically important that they report these symptoms at the onset. So typically, if the earlier they're diagnosed with a toxicity, the better our outcomes are in terms of treating it. And they need to be reassured that even if they need to start on corticosteroid therapy, it does not negatively influence their response to that immune checkpoint inhibition therapy that they had gotten. So there have been several studies that have demonstrated they can still retain therapeutic benefit from the immune checkpoint therapy that they had received. So that should be just reassuring.
So you're saying you can not, just because you're giving them immunosuppression doesn't mean that it's going to completely counteract the benefit that they received from the drug.
Exactly.
And then would you re-challenge them with, let's stick to pneumonitis now. Say they had pneumonitis, you did, I would say 4 weeks minimum of a prednisone taper, and then you've do you re-challenge them at that point when they've recovered and they get down to being off of steroids?
If they had a grade 3 or 4 toxicity, no, that's not what's recommended in the guidelines. Grade 2 is a gray area. I think part of it depends on if on your scans you also showed therapeutic benefit. So did you have tumor reduction? Again, that's another point of shared decision making. It's a really gray caution area in terms of challenging.
So it's really case by case, I think.
Absolutely.
Yeah. I mean, moving on to colitis is something that we probably see a little less of in lung cancer as opposed to melanoma sees more of this. But, I had a recent case, it's an ongoing case of a gentleman with colitis right now who has been refractory to high dose prednisone. We did finally get a colonoscopy, which very much shows active colitis from immunotherapy in his bowel. I'm really into getting fecal calprotectin now. This is such a good marker to show, it has been for this case anyway, to show it was so high at the peak of his colitis, and he really hasn't fully recovered. And you can see that the fecal calprotectin is still pretty high. We have moved on to infliximab, which has not really helped. We're working really closely with GI, which they've done a lot of really crazy stuff, like some steroid enemas, moving on to some mycophenolate mofetil or tacrolimus type drugs. Marianne, what has been your experience with colitis briefly?
So briefly, as you mentioned, colitis occurs less frequently in the non-small cell lung cancer population than it does over some of the other diseases. But you want to move quickly. If a patient is refractory to initial corticosteroids within a few days, you want to begin to think that you need another immunosuppressant therapy. I think that's key. And also collaborating with our other subspecialists and helping to manage these toxicities, as you highlighted, is critically important. And the other thing I want to highlight for those that are in the community is that we have a lot of experience at the academic center in managing these toxicities, and we've got our subspecialists there, but there are many clinical practice guidelines that have been developed by national organizations such as the National Comprehensive Cancer Network, Society for Immunotherapy and Cancer, ASCO, American Society of Clinical Oncology, that can help guide you in a step-by-step approach in terms of how to assess these toxicities and how to intervene. So I highly encourage people to use those clinical practice guidelines.
Okay. And lastly, let's kind of wrap up talking about the endocrinopathies, which are probably the more common thing that we see, getting a baseline TSH and then finding hypothyroidism partially through. I mean, this happens fairly frequently. I think the package inserts say 10 to 20%, but I feel like it's more common than that. I don't know why. A lot of times with the endocrinopathies where you're seeing hypo or hyperthyroidism or adrenal insufficiency, we don't necessarily jump right to prednisone for these patients as opposed to just replacing the hormone. Marianne, can you give us a couple minutes talking about what the mechanism there is of the immunotherapy toxicity on these endocrine glands and how you might manage that?
So again, inflammation of the organs, particularly let's focus on thyroid since that's more common. Typically what happens is you've got inflammation of the thyroid gland. Patients develop a hyperthyroid picture, and then eventually that thyroid gland, after being hyperactive for a bit of time, will then lose its function and the patient will become hypothyroid. And that is a permanent immune-related adverse event. The patient will stay hypothyroid for the rest of their life. And you highlighted, Beth, that endocrine is a very unique toxicity, and typically we can manage this with hormone replacement, and the patients can successfully go on to be rechallenged or even stay on the immune checkpoint inhibition therapy, but being aware that they need to be on hormone replacement for the rest of their life.
Yeah, I think that's true. And then, hepatitis nephritis, we didn't talk really a whole lot about this, but again, same idea, the immunotherapy that overactive T cells are attacking either the kidney or the liver. And one thing I'll say about this, we're checking the labs, the comprehensive metabolic panel every time they're coming in. And these transaminases, especially the AST and ALT, when we're seeing hepatitis, inflamed liver from immunotherapy, it's usually not a subtle rise in those transaminases. These will go from like normal AST and ALT of around 50 to suddenly being 300 or 400 in a quick period of time in 3 or 4 weeks. That's kind of a red flag to me saying, oh my gosh, this went from being really normal to really high. This is probably immune induced. And most of the time we don't necessarily see their bilirubin go up. So you don't necessarily see them become jaundiced or anything like that. So it's a true transaminitis that, again, we would use those high doses of steroid like prednisone and then slowly taper them. Same thing with a quickly elevated creatinine, in the absence of them being dehydrated or just not drinking, we would use those high doses of prednisone. So I think really, to summarize, we definitely need the help sometimes of our colleagues in, GI or pulmonary to help us manage some of these things. But I will say, what Marianne said, look at the guidelines that are out there. Look at those guidelines. I mean, those guidelines are going to tell you how to manage them. And Marianne was on the NCCN guideline committee for immunotherapy toxicities. So you're really hearing it right from someone who developed these. Any parting thoughts, Marianne?
No, I think that just one little caveat to just be aware of is if patients are on combination therapy, it becomes a little bit more complex in understanding the differential about what is causing the toxicity, chemotherapy versus the immune checkpoint therapy. So really reviewing the timing of the onset and the pattern of that toxicity will be helpful in determining the management.
Yep. Well, thank you everyone for joining us for this, very quick overview of toxicities from immunotherapy. And we look forward to doing this again. Thank you.
Thank you for joining us today. Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/NSCLC6. Look for all of our podcasts on your favorite podcast streaming services.